and that's where a lot of the karma of medicine comes in. Karma in medicine, if you don't believe in it now, you will when you get in med school. It works fast and it works overtime in medicine. If I've got people with diabetes and their feet are numb, I know they've got a peripheral neuropathy. I could take them and do an EMG neuroconduction and charge them $1,500. Nobody'd say anything, but boy, that would come back to bite me. You know, you gotta, if you're not in it, if you're in it, and you'll know doctors who run a mill, a diagnostic mill, and it always comes back to bite them, and it should.
Do you not have to cover your bases, though, by giving that test?
No. If you diagnose something clinically, then nobody would fault you for, for making that diagnosis. You can, and you'll know it. But that's I'm sure it'd be lucrative to do it, but sooner or later they'd come back to get you. And if you're going into it for money, you'll make a lot of money as long as you provide the service in a benevolent atmosphere. If you do it to try to be, and I know y'all wouldn't, but if you do it try to be mercenary with, boy, I'm going to get this back and I'll make this on that, it just won't work.
How often do you have something unusual come in? You say a lot of the time you have just normal, whatever you have, but how often do you have something that you're just like, whoa?
Probably 15% of the time.
Really?
Yeah, a lot of neurology gets a lot of referrals. I don't know what this is. So let's just see what the neurologist says about it. So, we get, and a lot of those people end up being psych. But
do you pass them on to a psychiatrist?
We try to. A lot of them get very upset. We had a lady when I was at the beach, or when I was in Charleston, she's from Myrtle Beach. Dr. Marty Samuels, who's the chairman of neurology at Harvard, happened to be down with us rotating that day. And he's like the most famous neurologist in the world. And he was looking at this lady had jaw dystonia, and so she couldn't open her mouth. And she lost like 50 pounds. And Dr. Samuels was looking at her and said, boy, we're going to be able to help you. We're going to have to do this EMG in your jaw muscles, and we'll do a nerve conduction through the face. We'll be able to find out what's going on. But my attending leaned over to me and whispered, he said, this is all bullshit. I said, really? I said, and then the state paper came down and wrote up an article about her. It ended up she was crazy. She didn't have, it was a psych. She had psychiatric jaw dystonia. She ended up getting a peg tube for feeding, and then eventually it just went away. But the psych, the state paper had, this mystery case from Myrtle Beach. Even the doctor from Harvard can't figure it out, and the doctors from MUSC are stumped. It was all, it's just kind of psych. She had some secondary gain from whatever. You'll see a lot of that no matter what specialty you go into. About 60% of all your diseases have either a psych causality or a psych contribution. Even if you're a cardiologist dealing with heart attacks, there's still a psych component to it most of the time.
You ever been in contact with somebody who's just really crazy, just off their rocker?
Oh yeah, we see that.
What kind of things do they do?
Well, I had a guy I was admitting one night when I was an intern. He was convinced I was the devil, and then he was pointing at this biohazard. They had that biohazard alert thing. He said that was Satan. Then I got to looking at it. It does look like the devil. So even that guy who was just floridly psychotic there's a component of the truth to it. So he turned out to be bipolar. He had a hypomanic break with some psychosis. We gave him some IV Depakote. By the next morning, he was calm. He remembered me, but
not the devil.
No. But by the next morning, he was coming back. We see that a lot. Neurology and psychiatry see that a lot. That's I like dealing with psychiatric patients as a rule. That's usually something you can intervene. If you can get somebody to hold them down, you can give them a neuroleptic intramuscular, and if you can keep them calm till that kicks in, usually you can make a rapid change. So that's kind of neat. It's fun to do.
Was it permanent? Or is it just temporary?
Yeah, that guy is somebody that'll have to be on medicine for life, or he'll have another break.
But it did help him that quickly?
Yeah.
Wow.
That was when those IV, Depakotes and old-fashioned seizure medicine takes a long time to start working. They made Depakon, which is an IV form of that. So we gave him IV Depakon, which also works for bipolar. And he started turning around real quick. But that's neat.
Cool.
Some of the psychotic patients are really neat to deal with. Rarely they're a danger if you handle them the right way. It's kind of fun and rewarding.
Would you say that your job on a daily basis is more routine, or do you see a lot more variation with the cases that you have?
So a lot of it's routine, about 90%. Somebody's weak on their left side, okay, they've had a stroke. Sometimes you get a little jaded doing that, and sometimes you're surprised. Sometimes it's a brain tumor, it's not a stroke. A lot of migraines and seizures and things like that. After a while, you get in a routine. But there's enough to do by reading EEGs, going to the hospitals, seeing inpatients and outpatients, that it's a nice variety, so I don't really get jaded.
Do you usually get your weekends off? I'm sorry.
Here lately I've been getting my weekends off, and that's because I let the hospital buy me out. I was on just about every weekend for a long time. If you manage it, that's okay, but you got to really have your time off.
Yeah, how can you have a life?
Yeah, exactly. I got 3 kids.
What other cases do you usually see when you have to go to the hospital? When you get called in?
Usually you get called in, it's either an acute stroke or acute encephalopathy, meaning somebody just won't wake up, or seizures that won't stop, status epilepticus. It's usually one of those things. And like everything else, we have an algorithm that we go down. So lots of times you don't have to think. They don't want doctors to think. You don't want your doctor to think in the emergency room. You want him to be, or her to be able to go down an algorithm. So most of the time we can do that, but that's usually what we get called.
How do you remember everything that you've learned up until this point, like through medical school and whatnot, and like how do you apply it? Because you see people and you don't exactly know what they have. Like they could be walking in the door and could theoretically have anything. And how do you just know that, okay, well, what to look for and stuff like that?
Yeah, well, that's a good question. There's and again, it's kind of an algorithm that we go down. Person has this, and we need to do this, we need to get this image, or if the person has that, we know what it is, we don't have to do any further testing. And, most of the time we follow the algorithm in the office just like we do in the ER. But there's a lot of things that we, I have to get out a textbook quite often to refresh my memory, or Google an image of where this artery goes or where this nerve comes off. So I have to frequently rely on word association to prompt some memory from years ago, or go back and look it up real quickly. Every doctor does that. He gets out the textbook and looks at it.
What would you say is the main difference between private practice and working in a hospital setting?
Well, working in a hospital, you pretty much get to set your hours. And by the way, there's now neuro-hospitalists, which are neurologists who do nothing but work in the hospital. That's another subspecialty of neurology. But you get to set your own hours. There's not really a lot of surprises. You take care of patients in the hospital, then you go home. There's a lot to be said for that, and a lot of neurologists are going into that. As opposed to an outpatient practice, where you you need to do more and more, and you watch the bottom line. Boy, I've got to work in this extra patient in order to do this and that. You really have to watch the bottom line and work a little bit harder as an outpatient neurologist. And most neurologists still do kind of a hybrid of both. A little bit inpatient and most outpatient. But some neurologists are refusing to work in the hospital. In Washington, D.C., only 11% of the neurologists take call. They don't even go to the hospital. And the reason is because of the brain attack, which we talked about. That's hard on neurologists, having to be within 15 minutes of the ER so you can get there to administer that drug within 3 hours of the onset of symptoms. And that's a litigation minefield. And so, and it's a hassle too, and it's 24 hours. So a lot of neurologists opt just to not be affiliated with a hospital at all, not to take it on. That's why they're getting this relay thing, or telemedicine, which is another litigation minefield. Telepsychiatry, teleneurology, where the patient comes into an ER and they sit there. Y'all might have seen this. Say somebody's having an acute stroke. They sit there or lie there on the table, and the neurologist is watching remotely from wherever he or she is. It might be 200 miles away, and the nurse does the neurologic exam, and the doctor looks at the CAT scan and says, okay, we need to give the TPA, that clot-busting drug. And so as you might imagine, that's a litigation minefield. Say they have a mishap, you can see that neurologist 6 months down the line on the stand. Doctor, exactly how far away from the patient were you when the TPA was administered? Well, you wouldn't have a leg to stand on. So, but telemedicine, telepsychiatry, where they put a psychotic patient in front of the camera, and the psychiatrists try to figure out what's going on. The ERs are trying to start that now. That's a litigation minefield.
Can I just take away just from the personalness of the whole thing?
Absolutely.
Isn't that really the whole point?
Yeah, I mean, that's why you go to med school. It's part of it, learn how to do the physical exam and then the exam within your specialty. Boy, if you let that go, then everybody loses the doctor, the patient. But they're trying to do things like that because doctors are balking at coming in and taking them on. And I can understand that you've been through internship, med school, residency. You don't really feel like working that hard, then you shouldn't have to in a lot of ways.
How often, if ever, are you put in an emergency situation where you have to act quick, like you would in an emergency room like that?
Once a week.
Really?
Yeah. It's been crazy. I've been getting a lot of calls to go. The last few nights I was on call at our local hospital. Every night I had to go in. There was a brain attack every night. And, it's been happening a lot. A lot of it because of publicity. People are saying, if you have these symptoms, call 911. And so they're doing that. So a lot of people are arriving earlier at the ER, so we have to go and do that.
You get a lot of false alarms.
Oh yeah, a lot of those people, most of the people either, some of them have a bona fide stroke, they really need that clot busting agent. Most of them are having a TIA, which is reversible symptoms, or a migraine, or they're depressed, or they're having a psychiatric issue. A migraine with some people can cause a hemiparesis where they get weak on one side, it can mimic a stroke. If those people get a clot busting agent, it can be catastrophic. So you really got to watch what you think about it. And it can really fool even an experienced neurologist. That clot busting agent can cause rip-roaring hemorrhages throughout the body. So it's a little tricky. But it's, a lot of emergencies they turn out not to be so. But you can turn it into one by doing it wrong.
Have you been sued?
Never been sued. Actually, I did get sued by another neurologist. I brought her in for 2 days, and she worked with me for 2 days, and everybody in the office said, either you get rid of her, or we're all going to quit. And so we had to fire her, and then she sued me, and then I countersued her. I ended up winning everything, but I didn't get a dime. So the patient's never sued me.
She was just a jerk.
She was working at a fast food window in Florence when I hired her. She was an ex-nun. She was a neurologist. I've never...
The next nun neurologist.